So I had an experience at a clinical rotation during a baby delivery, and my this was first semester in the program. I felt like I was pretty new to the whole respiratory thing, and I didn't really have much of an idea of what was going on. Because originally, the kid was grunting. I was like, "Oh, he's making an effort to breathe. That's a good thing." And we'll touch more on that later. Why that wasn't a good thing, but um, the kid was an emergent C-section delivery. Mom wanted to deliver at a hospital that was like an hour and a half away from where we actually were, and she was having contractions like 10 minutes apart. There was no way they were going to make it to that hospital. If the husband had done what the wife wanted to, they would have delivered the kid on I-15, and nobody wants to deliver a kid in the middle of highway kind of thing. So good thing the husband stepped in and took initiative and went to the closer hospital and delivered. We had this kid, but it wasn't like super early. I would say I think the kid, if I remember right, was like 30 weeks. Um, I just had a hard time breathing. So they were doing PPV at first. It kind of improved the breathing at first, but it wasn't enough improvement to be safe to like discontinue assistance with breathing. So they intubated the kid and they also administered surfactant, which we're going to talk more about later as well. But that just helped open up airways at this time for this kid. And with that surfactant treatment, I thought it was interesting that we had to have the kid on one side for, uh, I guess this hospital's policy was a little different than what I think I was taught in school, but the kid was on one side for like a half hour. We turned him to the other side, gave him another dose. He was on that side for a half hour, and then he had to lay flat for 3 hours. So a total of about 4 hours where we didn't really touch the kid that much. But I just remember that situation very vividly because, especially because this baby had family from like Washington State visiting, and it was like a grandma and grandpa, and they really wanted to hold their newborn kid, and they couldn't because we had just given this kid surfactant, and like I said, you don't want to touch the kid after a certain amount of time. They were all butthurt because they had to catch their flight, and they wouldn't be able to hold their kid. But hey, it's sometimes that's what you got to do to keep a kid alive. Is you're not always going to have family that's happy with you. So, and that's pretty much my clinical story for this episode.
And it's a pretty good textbook example of when NRP is needed. So, listeners, NRP is neonatal resuscitation practice. It is basically some guidelines that a panel put together to basically standardize emergent care for newborn children. It's actually fairly rare that we need to resuscitate a child, just due to a lot of the times when they come out of the womb, they do pretty fine. But there are, of course, always times where we need to actually resuscitate them, whether it's they're having difficulty breathing, or they're premature, so they have higher risks. If even sometimes they have some heart issues, though that's pretty rare. So NRPs just set guidelines that uh, you can get certified in and trained in to attend these deliveries and really just watch the kids and make sure that everything's being done that needs to be done and how to save their lives if need be. It's available to both nurses and respiratory therapists, which is nice. And it's especially nice for respiratory therapists because NRP actually is more of a respiratory um, set of rules than it is anything else. This is primarily due to pretty much every resuscitation that needs to happen isn't because of an issue with the heart, it's because of some sort of respiratory failure. So, and this is due to tons of different things, whether it's a problem with a different body system, whether it's a problem with the heart. But in infants, unlike adults, one way to really help them out is to just provide positive pressure ventilation, or PPV. Well, it's great.
I agree with you, Nick. I think it's interesting. It was kind of a transition because I was used to working with adults, and if an adult coded like had a heart attack, the main focus was keeping the heart working. And with babies, and I feel like with kids too, more of a priority is ventilation instead of circulation. Especially as we go through this algorithm, you're going to see that when you assist with ventilation, circulation and perfusion follows. Like it'll improve with effective PPV, like positive pressure ventilation.
I also think, like Nick already pointed out, but this is very rare. Even the positive pressure isn't always needed. Most of the time, just like drying the baby off, rubbing their back and their legs, and getting them stimulated is enough to like get them crying, and they do it themselves. Most of the time, the resuscitation, like Nick already said, isn't even needed.
And what Trevor was talking about, that's also in the business, I guess you could say. Those are the initial steps, like warm, stimulate the patient, like monitor their temperature. Like when you suction a baby, you usually use like a bulb syringe, which I think is good for like delivery, but for long term, I don't recommend it because I feel like those things are a breeding ground for bacteria. But that's what you would use at first for resuscitating a kid. Like it's a really quick, easy suction method to use. But yeah, those were the initial steps, which is a part of the algorithm we'll go over.
Oh yeah. So when thinking about NRP, it's important to just kind of know what is actually happening internally with the child when they're born. So in the womb, fetal circulation is much it's far different than after birth. So in the womb, of course, the all the blood, all the oxygen to the blood is being supplied through the placenta. So the mom will take certain nutrients and basically, from my understanding, is supply it through the or circulate it around the capillaries in the uterus. That will, when connected to the placenta through a very thin membrane, these nutrients and the oxygen, all these molecules that the child needs, will transfer over to the placental blood, which will then, of course, be carried through the umbilical vein to the neonate, or I guess at this point it's not a neonate, the fetus. That's the correct word. So through the umbilical vein, it will of course travel to the heart. It bypasses the liver so that you know the liver doesn't have to function, because there's really no need to try and filter out uh, a lot of the nutrients and process them in the liver, because mom already did that step for us. But it will bypass the liver through uh, the un- the ductus venosus, as is known, which is just a little duct that connects the umbilical vein to the inferior vena cava. Through there, it will follow normal blood circulation for the most part. But due to the lungs of the child not being developed as much, just because, we could be at 20 weeks or 29 weeks or whatever. Uh, if the lungs are developed, the alveoli are going to be full of fluid. They're in amniotic fluid. It's it's just the way we're made. So lungs are filled with fluid, which causes the pressures in the heart to actually be swapped. So what this does is, instead of the blood wanting to travel to the lungs and get oxygenated, where when they're in utero they can't anyhow, the blood will actually travel through a hole between the atrium of the heart, called the foramen ovale, which will make it so that oxygenated, that nutrient-rich blood actually still makes it to systemic circulation. Now, if any blood doesn't make it through that hole, that foramen ovale, there's also another duct similar to the ductus venosus, called the ductus arteriosus, that connects the pulmonary artery trunk to the aorta. So, and that's just another redundancy that allows the child to take that oxygenated blood and get it into systemic circulation. Now, through systemic circulation, the now deoxygenated blood, the nutrient poor blood that has all the waste that the child needs to get rid of, it will then, at the descending aorta at some point, will split off into two umbilical arteries that go back through the umbilical cord to the placenta, where that waste can be given to the mother to, excrete. What's cool is how all these openings, these redundant openings to make it so the fetus can survive in utero, how they close. So when a child is born, what happens is they take their first big deep breath. What this does is it, of course, will inflate the lungs and inflate the alveoli. Now, yet you may be thinking, there's all this fluid in the lungs. Where's that going to go? Are they going to cough it up? Well, no. That fluid actually ends up getting absorbed by the alveoli and plays a certain specific role in helping get your lungs developed and to help produce more of the type 1 alveolar cells. So that lung fluid, that fetal lung fluid, gets absorbed, or should get absorbed. There is a condition where it doesn't, but that fluid will get absorbed. Those alveoli will expand with air, and because of that, the pressures in the heart will actually flip to how they should be, causing the right side of the heart to be a lower pressure and the left side of the heart to now be a higher pressure, which literally causes all of those openings to close with just a little flap and stay closed. It's actually quite fascinating. But these openings will then, after they're closed, or after they should close, they will basically, what's the word? They will fuse, and become just a normal part of the body after a couple of days. So it's fascinating how just that first breath will cause these lungs to inflate, and then just let everything start working. It is the breath of life. So
Nick, I totally agree with you. It is kind of like when they say childbirth is like a miracle. A lot of these things, like the circulation of the blood, um, heart defects, just how resilient babies are, is proof of that. And as we kind of go through the algorithm of like when babies actually do need help, it's eye opening to me at least, just how quickly they turn around by like little simple things. They just immediately turn around and make a full recovery.
I remember the one thing that I learned in while we were talking about NRP in class was how amazing it was that babies really are like when they're born, they're not it's not like their first time doing these things. Like they're doing a lot of these normal things, like they're breathing in the womb. They may not be breathing air, they're breathing that amniotic fluid, which is then absorbed, but um, I thought it was kind of cool that that's what they're doing, so that day one when they're born, it's not like it's actually day one, if that makes any sense.
oh yeah, for sure. And where NRP comes in is when that first breath doesn't work for some reason, whether it's the alveoli, the child doesn't have the musculature developed yet to take that first big deep breath, so they have all this fluid in their lungs still,
And
or if their heart doesn't, those openings in the heart don't close.
also, like most of the kids that are needing this resuscitation are early. And one of the last things that develops while they're still in utero is the lungs. So if they're born early, the lungs don't get fully developed, which kind of important. It's going to lead a lot of those issues, like you already said, Nick. They aren't going to be able to get all of that fluid out of their lungs when they need to, or be able to utilize them as well as they need to. And I think it's one of the things that can benefit these babies, especially if you are at risk for like delivering early, is they talk about like antenatal steroids that really help to improve the lung condition before the baby's actually born. Helps to increase the growth and maturity of their lungs so that they can perform at a higher level when they are born, rather than if they didn't take those medications, the mom being didn't take those medications, the baby probably wouldn't develop like they should, and then would be forced to need some sort of resuscitation measures after the birth.
I actually have a story to go along with that, with having uh, kids. One that two of my kids were definitely premature. One had steroids and the other one did not. My first kid was in the NICU for 2 weeks, and I kind of accredit that to the early administration of these steroids to help develop lungs in a fetus. And with my second kid, it was almost unnerving when we were only at the hospital for like 24 hours, and they said, "Here you go, you're good to go home." I was like, "What? No 2 weeks stay in the NICU? No breathing problems?" It was just night and day difference. Like, it's just crazy.
Oh yeah, those antenatal medications and treatments really help. They're honestly, they're one of the things that I would advocate for the most, for expectant mothers to do, and consult with their labor and delivery doctor to really just make sure that they're doing everything that they can to make the process as smooth as possible, because you know they might have a premature child, and if they do, that child's going to struggle and will probably have to spend a lot of time in the NICU, and that's it's not great for the child, and it's not great for the parents. It's a lot of stress, both financially and emotionally.
Oh yeah, definitely. It was an emotional roller coaster. Like occasionally having to leave the hospital with my first kid, like in the NICU. You have so many thoughts going through your head, like, "Am I a bad parent for leaving my kid?" and stuff like that. But in those situations, you need to make sure that you're taking care of yourself as a parent, because you're the one taking care of that child. But it's also kind of interesting that, um, like the use of steroids to help develop lung function. I thought it was interesting in class when we learned that your alveoli, they develop until you're 8 years old, which I think is crazy. And is it at that point if you spread out your alveoli, it would be like the surface area of a tennis court? Is that like when you're older as an adult?
I think
You
that
guys know?
probably is at the age of 8. Or actually,
Mm.
yeah, it would probably be when you're an adult, because I think what the 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 measurement of your alveoli keep developing till you're around 8 years old, which is true. It has been proven. I think that really corresponds to, you will have the amount of alveoli that you will, uh, for the rest of your life. Of course, the cells will die off and regenerate, as all cells do in the body. It's just part of life. But
Right.
I think as we age more, the size of the alveoli increase, because of course your lung size and your lung capacity will increase the older you get up until a certain point. So I think
Right.
the tennis
It's
court
just like your
measurement.
muscles.
Oh yeah, absolutely.
Like you have the same amount of muscle fibers, but as you like exercise and stuff like that, those fibers get bigger. But yeah, it totally makes sense.
Oh yeah, absolutely. So I think that tennis court measurement is more for like an adult with like no lung complications and no developmental defects or anything. But
Still, that's crazy, but it kind of sounds morbid to people that don't work in healthcare. We're talking about spreading out stuff all over a tennis court size.
oh, it's fascinating. It's like the like how long your intestines are end to end, that sort of thing.
Oh yeah, that's another crazy thing, but that's not what we're talking
But
about today.
that's besides the point. But
That's another day.
but yeah, it's amazing that we can perform steps to help these children if they can't get that first breath.
I
But
think my after kind of going over all of this, like um, what point do you realize like a baby needs resuscitation? And I think that's when you just jump into a really good assessment of like what's going on with the baby. A couple quick like initial assessments that we're taught is our ABCs. Um, check the airway, make sure the baby's airway is good, that it's clear, make sure that you've suctioned out everything that you can. Check their breathing. Are they breathing? How fast? Are they putting forth a lot of effort when they breathe? And then check the circulation. This is going to be done through like heart rate and color. Most babies are not born pink, they're pretty blue, and they stay blue for a little bit. And gradually, as time goes on, they slowly change. But those are quick, like initial assessments to just see, like, oh, are we gonna need to do something more? Is this baby gonna be able to make a recovery by itself, or how much are we gonna help?
oh yeah, those initial questions are, you know, super important. So and those that initial assessment is everything. So from there, I think Drew, do you want to bring us into the algorithm, talk about it a little bit? So give us the first things we do after we do that first initial assessment.
Yeah, absolutely. So, beginning with the algorithm, you're wanting to get a little bit of information as well about the baby um, while we're anticipating for this. So we want to know like how is the antenatal, like what's going on, or as well know about maybe do they know about any of the like diseases or anything that could possibly complications that could come from this birth, as well as how many babies are being delivered. And that will help us to be prepared for when stuff does kind of hit the fan, so to speak, and we need to step in and do our life saving measures. Um, but as you go down the algorithm, um, you start out at birth, and then we're looking at, like I said, the term gestation. Does the baby have good tone? Like, do they look pink? Are they blue? Because seeing how the baby looks is a good initial step to see what kind of steps we're going to need to take later on. And then, like Trevor was saying, you got your breathing, or are they breathing or are they crying? And then this is where it kind of starts to split off. And if they have yes to any of those questions, like the good tone, term gestation, or breathing or crying, then you're going to go over to the box that it's going to say the infant will stay with the mother for routine care, just warm and maintain and keep the baby at normal temperature. Make sure that the airway is good and positioned openly, and just you know help clear secretions as needed. And that's when our job is kind of just to help monitor, and we don't really have to step in. But when it goes south and there's a no in that out those questions, that's when you start working down the algorithm. So the next step would be to warm and maintain the normal temperature position. position the airway, clear secretions as needed, and dry and stimulate. And I think having talked about that and gone through our NRP class, I think all four of us were in the same class together for our licensure. The one thing that they hounded on us was your temperature. A lot of us didn't realize that even if we left like a wet rag that we use to help clean up the baby, that could help, or that could actually be pretty detrimental to the baby's temperature because it's still wet and it's sucking all that temperature or sucking all the warmth out from the baby. And so that's something good to kind of keep in the back of your head. But then as we're doing that, we're also looking for, is the baby apneic or not breathing? Are they gasping? And then the other part is our heart rate below 100? And then if there's no, then we check to see what kind of breathing they're having. Are they having labored breathing? Is their work of breathing getting worse and worse? And are they looking more cyanotic? Or are they just looking blue? And if the answer is yes to that, then we want to position their airway and help try and clear it, just in case there's something maybe blocking their airway, and that's why they're not getting that air into their lungs. And then that's when we want to start checking, get like an SpO2 monitor, and we put it on their preductal, if I remember right, which is their right hand, and that's where you're going to get the best oxygen reading on an infant or a newborn.
Yeah, so with that preductal saturation, what that means is it's basically it's before that it's the section of the body that is before that ductus arteriosus that I talked about in fetal circulation. What that means is it's basically the area of the infant that is being just oxygenated and ventilated by the infant themselves. It doesn't have any of mom's circulation going on or anything to do with that ductus arteriosus. Because if that doesn't close, then you're going to have some differences in oxygenation. So because you'll have a little bit of a shunt going on. So you want to get that oxygen probe on their right hand or right wrist because it'll be a better representation of what the child is actually doing.
And it's also pretty normal for that to start out pretty low, and gradually over about 10 minutes is when it gets up to where you'll start feeling comfortable with it again. So it's pretty easy to remember if you're counting on like one hand using each finger. One finger for 1 minute, your saturation should be about 60%. At 2 minutes, when you got two fingers up, it should be about 65. 3 minutes, 70%. 4 minutes, 75. And then at 5 minutes, it should be 80 to 85. And then after that, they just jump up to about around 10 minutes. You want to shoot for the SpO2 to be about 85 to 95%. So it does take a long time, which can feel kind of unnerving. But it is totally normal for it to take a little bit and to remain low for a little bit. And just as the baby is getting the needed help that it needs, it'll slowly start to come up.
Yeah, I remember learning about those target saturations and thinking that's completely backwards from what I'm taught. Because like Thomas, I also work with adults, and as soon as anyone dips below 90% on their O2, it's like, oh crap, we better hurry and get them on oxygen. But it was pretty interesting to learn that it's okay for a baby at the very beginning to be low down in the 60s, and that's actually good. That's where we want, as long as we're maintaining these steps like Trevor was talking about. It was that this is where we want to be. It's okay for them to be at 60 and these lower numbers at the very beginning.
Not only is it good, but if you give too much oxygen, it can be a bad thing for the baby and cause actually more damage to the baby than it would do good.
Exactly. You can actually, from giving a child too much oxygen too early, In the algorithm, it has like target oxygen saturation for each time. If we're ahead of that, we can cause damage to the retina, and you can actually cause blindness. So you need to monitor that super closely, and it seems like that's mainly based from minute to minute. So it feels like time is slowing down in those time frames. If you're not on top of it, you can definitely get behind and or even ahead, like over oxygenating. Because I feel like in those emergent situations, you almost panic sometimes, and your goal is like, oh, we need to shoot for above 90, and that's not the best practice before 5 minutes, kind of thing.
Yeah, absolutely. It's important to keep that oxygen under wraps. But Drew, you willing to continue on with the discussing this algorithm?
Absolutely. So, and the good thing, and the thing to note as well is all the stuff that we were talking about with monitoring the baby when they are here. Like, are they apneic? Are they breathing? How hard are they breathing? This is all done within the first minute of life. But if on the other side now, the algorithm, if they are apneic or if they're gasping or their heart rate is below 100 beats per minute, then that's when we need to start thinking about PPV that we mentioned earlier, and that stands for positive pressure ventilation. And we can talk a little bit more about that, or unless you want me to talk about it now.
Yeah, good. Little brief summary. I mean, it's an important concept. It's PPV is your bread and butter in NRP. I think the statistic, and correct me if I'm wrong, which I probably am. I'm just trying to recall a number here, but I think something like 90% of resuscitation attempts can be solved with just PPV. Just because it's as soon as you get those alveoli open, if there's no congenital disease going on or no other issue happening, that PPV will that child will be able to stabilize just like that. It is quick.
Yeah, and there's multiple devices, and the one thing that I found interesting in class was it doesn't really matter which device you use as long as you're good with it. And that would help keep those, like Nick was saying, was keep those alveoli open to help ventilate and help the baby start to breathe better and maybe oxygenate at those target ranges. Um, but then we also want to start checking their SpO2 again, that they're pre-ducted like we were talking about earlier. And then we also maybe want to start putting on some ECG leads to help monitor their heart, make sure that their heart waves are doing okay and that their beats per minute are doing good. The next step down is you want to also again check to make sure the heart rate is above 100, and if it's not, um, then you want to make sure that you're checking like their chest movement. Is the PPV doing what it's supposed to? As you're giving that PPV, you want to make sure that you're watching, make sure that you're getting good chest rise out of the baby, because that way it'll help you to know that you're actually ventilating the baby and doing what you need to, or if there's maybe like a blockage in the airway, and that's what's blocking their lungs from inflating and getting that air that they need. Um, and then that's when I believe, correct me if I'm wrong, that's when you want to start checking like your Mr. SOPA. Um, and then we'll talk about that as well. But it's mostly a maneuver to help make sure that everything we're doing for the PPV is doing what it's supposed to be doing.
Yeah,
And that,
Mr. Soap is actually a very good tool. It's a mnemonic that is used for correcting positive pressure ventilation if, say, you're trying to ventilate a child, or I suppose you could even use this for an adult in an emergent situation. But it's a mnemonic mostly used in NRP for correcting PPV if you're not doing it properly or if you're just not getting the results you need.
It's pretty much like troubleshooting, like, and double checking yourself when you're ventilating a baby. And if I understand right, I'm pretty sure that's something that you assess at the 1 minute mark. if your heart rate and stuff isn't improving in the child, or I guess in the infant, the baby.
Yeah, I think you're correct. And most of the time, the Mr. Sopa will kind of resolve the issue, and you'll start seeing a change as you go through those corrective steps.
I I thought that you don't have like a hard timer for when you would perform Mr. Sopa. You just kind of look at the child as you're trying to ventilate them and then go through the steps just as they appear. Because if you are giving PPV, you should see a response in chest rise is the main thing we look at with PPV. For just seeing if we're doing it correctly, you should see that immediately as soon as you're giving breaths. So I feel like it's probably important to not wait on performing Mr. Sopa if you suspect that you're not doing adequate PPV.
I would agree with you, Nick, on that one. If you're not seeing that chest rise, there's clearly something going on. Whether and those of you who don't know what Mr. SOPA means, it's a simple 6 step ventilation thing that we can do to help make sure that we're giving the proper ventilation to the infant. And it first starts out with your M, which is mask adjustment. So if we're giving PPV, we're putting a mask on that baby, and we want to make sure that mask is actually in a good position, because if it has any kind of leak, that may be where all your pressure is going, and that's why you're not getting that adequate ventilation in the patient. The next step would be the R, which is reposition the head, and you want to reposition the head just because you don't know if you maybe where babies are so I don't know what the word I'm looking for, but we just want to make sure that their airways are not being pinched off, or there's their head or whatever is causing that a disruption of airflow into their lungs.
I would
The next
say
thing,
like babies are positional. Like I think that's the word you were looking for, Drew. Like it's pretty easy to go too far one way when you're trying to
exactly,
like ventilate a baby. Why do I keep saying it? I guess that is a patient, but I just keep thinking of adults when I say patient. But babies, when ventilating a baby, yeah, you need to. I think it's more crucial with babies than adults, like managing that airway, because you can go too far either way real quick.
exactly. And once you reposition the head and you're still not seeing that chest movement, then maybe you might want to start suspecting that there's something maybe in the nose or the mouth. So you want to make sure you're suctioning the mouth first and then the nose to make sure that they haven't aspirated like um, the meconium that they could be possibly swimming in. So that way you can help clear their airways and make sure that there's no resistance in their airways. And then make sure you open them. You want to then do your O, which is open the mouth. Um, and then you want to start working on your pressures if you still don't see chest rise. So you start to increase your pressures by 5 to 10 centimeters of H2O increments, and you don't want to go any higher than 40, because then you start getting into that gray area of maybe giving the baby a pneumothorax, um, and all that other kind of stuff with those high pressures, since they're still giving their lungs a good old test drive still, and they're still being developed. And then the next thing, if none of those are working, you want to maybe start thinking about an alternative airway, which is your A. And so which is like your endotracheal tubes and um, laryngeal mask airway, which is something that it's a mask that just blocks off your larynx and then keeps those pressures inside your lung. Um, and these are just kind of six simple ways to help make sure that you're giving that the ventilation the baby needs.
Yep, Mr. Sopa is one of the biggest tools that we have to just absolutely make sure that we are giving that PPV that they need. Because PPV is, as we've said before, the most important part of NRP and neonatal resuscitation. And just, I think generally in life, you need to be able to ventilate. If you can't ventilate, you can't do any of the other necessary functions you need. So, but yeah, so after you give 30 seconds of functioning PPV, so that is just PPV that moves the chest, you would then move on to the next step. Right, Drew?
Exactly, and that would be, again, you're going to want to keep monitoring the heart, and then at this point, after 30 seconds, if the PPV, the heart rate starts to go below 60, anytime the heart rate starts to go below 60, that's when you want to start doing chest compressions after that 30 seconds of PPV. Um, and then you want to do it at a rate of, if I'm not mistaken, about 120 to 150, right?
Yep, that
Or is it 100 to 120? I always get these
I
mixed
believe it's
up.
a
And so,
100 to 120. Because you're wanting to, it's I believe that you do 120 total actions when you are doing a cycle, a CPR on a neonate, with 90 chest compressions, 90 to 100 chest compressions with 30 breaths. I believe that is the appropriate amount. So I believe a rate of 100 to 120
You're correct.
compressions is right.
You're
okay.
correct. And then if you have someone with you, you can do like the ratio where it's like 3 compressions to 1 breath, which that's what it equals 120 a minute.
Right. And then, so in the algorithm, if you do notice that the heart rate is below 60 and you're starting to do chest compressions, that's when you would also want to strongly start considering to intubate the patient if you haven't already done it. And that will also help alleviate that stress of wondering whether the airway is closed off or not. And that's when you would also start to go into that ratio of, it's, if I remember right, it's 1, 2, 3, breathe. So you're giving 3 chest compressions per breath, and that will help keep the heart rate or the circulation going like it should be, as well as the ventilation to the baby going like it should be. Um, and then you're at this time you're also giving 100% O2 because there's something clearly going wrong, and in this case where it's super emergent, you want to make sure that the patient is getting that 100% of oxygen. Um, and then you also want to, if you haven't already done your ECG, make sure that's on there, as well as maybe you can start considering doing a UVC. UVC is an umbilical venous catheter. It's a catheter that we would stick instead of having to poke the baby, since their veins are so small now. At the very beginning, we can actually use their umbilical cord to insert a catheter through their venous vein, yeah, their venous entrance, and help to monitor a little bit, as well as push medications like epinephrine if that comes to that point, to help rescue this baby. And then if their heart rate still is not at 60 beats per minute, then the algorithm starts suggesting using an IV epinephrine, which you would have established being able to do through your IV, or sorry, UVC. And then it says, and if heart rate is persistently below 60 beats per minute, consider hypovolemia and consider maybe a pneumothorax.
So if,
And then,
say, if hypovolemia is suspected, we will actually give a volume expander, which is just a bolus of saline, just infused into them to just increase the amount of fluid circulating through them, so that they can actually properly get blood moving. Because without fluid in there, can't really transport things very well. You have a super high vascular resistance that the heart has to pump against, and an infant's heart, while strong, can't isn't that strong. And for a pneumothorax, that's another special consideration. That likely won't have happened naturally from the baby being born in, say, resuscitation. It is more likely to happen due to your PPV. After the infant's born, spontaneous pneumos just happen sometimes, just because their body isn't fully developed, so they don't have the protection from that. But if, say, pneumothorax is present or suspected, you can actually use what's called transillumination, which is basically you take a light and a special light that's super high powered, and you stick it on their chest, and if there is air in the pleural space where it shouldn't be, or in the thoracic cavity, that is, it will basically kind of cast out over the chest into what is known as a halo effect. And if that happens, you have to perform a thoracentesis, which is just, or a neoaspiration, either work. And what that is you go over a certain rib with a needle to just evacuate the air through a special procedure. It's actually rather interesting that we are able to do this, but it's one of the other life-saving techniques we need to know. So an NRP does teach you how to perform an emergent needle aspiration. So
There's a lot of steps in this whole thing, and I don't know about you guys, but when I was reading over it for the first time, it seemed like really overwhelming. But then as we started actually doing it, like it's a very, very quick process. And I was surprised not only how quick it is, but like how quick the baby's reaction is to it.
oh yeah, definitely. I mean, as you read through this and as we are just talking about the very basics of it, we've spent somewhere around 15-20 minutes just going over the algorithm itself. And when you're in an actual resuscitation, all this stuff is usually done within 5 minutes.
Yeah.
So experienced therapists can get this done in 3 minutes. It's amazing.
I
I think
remember
it's
like one of
also, oh, sorry,
oh, go
but I
ahead,
think
man.
it's important to know as well that it's not just one of us going through this entire algorithm. Before this is even starting, this NPR, or yeah, NRP, sorry, not NPR, um, that we actually have specific rules that we are doing. Like, for instance, Trevor would be over airway, Nick would be over, I don't know, say medications, Thomas would be over establishing a UVC. Everyone there has a role to play, and so that's why looking at this, it's probably overwhelming. But in actuality, you just have one specific role that you are in charge of, and you just need to know when your role is needed.
I,
I remember
I just want to add two things. Oh,
go ahead, man.
okay. Yeah, like they're saying, the algorithm looks overwhelming, but when you are actually doing it, it's not it's not bad at all. And I think it's crazy. Like most kids turn around like in 5 minutes, like 10 tops almost, which is crazy to me. Working manually with adults, like I've been in CPR like code situations where we've been doing resuscitation for like 30 minutes to 40 minutes, and it just blows my mind how quick these babies turn around.
Yeah. One of my first like clinical experiences that I had was one of the respiratory therapists grabbed me and took me on a C-section delivery. And I wasn't in the room for the C-section. They actually put us in like a different room, and then they would like walk the baby over to us when it was done. But they walked before they walked us over. The therapist that was kind of like teaching me some stuff more or less went over this algorithm with me like really quickly, and she's like, so this is what you're going to do, you're going to do it as quick as you can, but you're going to follow these steps. And she's like, if you have any questions, I'll be right there. And I was super overwhelmed because I'm like, this is a brand new baby, you're going to trust like a brand new student with this. This is like big time scenario. And then the baby comes in, and I just started doing the stuff she had told me, and I realized like this is so easy. Like it's a very serious situation, but it was like very easy, very quick, and the baby only ended up needing to be on like CPAP because the oxygen wasn't coming up as quickly. So we like suctioned out their stomach and then put them on CPAP, and then you could literally see the baby's skin like go pink within like minutes, and it was like super crazy. But I was way overwhelmed at first, but then as I went to do it, I realized, oh, so simple, so easy, and still so effective.
Yeah, one of the best things about NRP is that it is standardized and made to be, as relatively simple as it can be, so that in these situations, if you have someone that maybe hasn't done NRP in a long time, or is a new student, or a new hire, they have the ability to go through this process with as little hiccups as possible. And thankfully, there's always that support system that you have. You have a team there to help you.
Even many facilities that I've worked at, they have this algorithm posted in like delivery rooms and stuff like that. So I'm not saying that you should use that as a crutch. Like I feel like you need to know this algorithm inside and out, but it's also nice to know that you have a reference if you need it.
So after the resuscitation, there are certain things that uh, not necessarily we as therapists do, but just the whole healthcare team for these infants has to do. Any infant requiring resuscitation methods has to be admitted to a NICU. I believe that's just standard. Some hospitals may not follow that rule, but that is a case by case thing. But for the most part, they should be transferred to the NICU for monitoring for some time. And what is monitored, and some things you need to keep in mind is you know temperature control is a huge thing with these babies. You don't want to overheat them because it can modify their respiratory drive, but you also don't want to underheat them because it can modify their respiratory drive. Temperature is a huge thing to consider. Another big thing is their glucose levels. In a resuscitation, they're usually burning off as much glucose as they can in their blood. So they're going to have low blood sugar, and that's, of course, going to affect their ventilation. So you need to monitor them and, make sure that they have appropriate blood levels or blood glucose levels. Um, yeah, that's pretty much the basics of post resuscitation care. Of course, there's they just need to be monitored, make sure that they don't have any pneumothoraxes, they don't have any heart defects, or any other congenital defects that suddenly arose. And you need to make sure that they don't go into respiratory failure after they've been resuscitated, because sometimes, and I think it's actually somewhat frequent with many infants that are admitted to the NICU due to resuscitation efforts, that sometimes they just have long periods of apnea. And while sometimes it is stuff that we do need to treat with PPV, other times it's just stuff that naturally happens with babies. So you just need to keep an eye on them, make sure they're stable, and after certain goals are met with them, they can then be discharged, which is nice. So, some things that are unfortunate that need to be discussed, need to be known with NRP are some of the ethics behind it. Do any of you want to just give just a brief overview of some of the ethical considerations that need to be met?
I guess I could talk about that. Some of it at least. I don't know if I know it all well enough, but we need to make sure that we're including like parent or guardian with cares, especially like what extent they want us to go to preserve life. I think in most cases, too many people they just consider the quantity of time that somebody has versus the quality. That's something that I think of personally. Like, would if somebody had to resuscitate me, what is the quality of life that I personally would have or my kids would have? I just want people to consider that when they're thinking of worst case scenarios. Like, obviously, we prepare for the worst but hope for the best in all medical situations. But especially with like newborns, if the kid is only at 23 weeks gestational, or like gestation, um, that kid's gonna have a rough go. We they've been able to like keep kids alive at that age, but there's a lot of things that they have to do to keep that kid alive. Um, like we said, like the lungs are probably not developed very well. Alveoli, we're waiting for those to ramp up. Some cases, kids' eyelids aren't even developed at that point. Um, yeah, I don't want to get too morbid, but you at that age of 23 weeks, the parent can choose to terminate the kid or not. That's a very serious thing to consider, but that's something that parents have to decide because they're the ones that are going to be taking care of this child if they decide to proceed. But gestational age, premature is up to 37 weeks. Gestation, past that is considered term. Um, and if you, I don't, I haven't seen it happen too much nowadays, especially that we let kids go past um, like 40, maybe even like 38 weeks. But when you get past that mark, you have the risk of meconium aspiration, which is pretty much kids breathe in poop and stuff like that, kind of. Um, but that's pretty easy to manage after that. But there is that window between like 23 weeks and I would probably say like 32 weeks, where you have to consider options. Um, yeah, I don't know if anybody else wants to chime in on that, but I hope all parents consider that when preparing to bring a kid into this world, in this life, is what extent or do we want healthcare workers to go to?
I think that's really important, Thomas. Also, um, even after the parents give their consideration, most doctors won't stop resuscitative efforts until every single person that's in that room has all come to the same conclusion that yeah, we've done enough. But if like one person feels like we could do more, then they keep trying. From what I've been told, I guess, because I have never been in one of those situations. I hope to never be, but I'm sure it will happen eventually. But it gives me a confidence knowing that like everyone's gonna do 100% until there is literally 0% left.
And I feel like the ethics behind it is you need to put your personal opinion to the side, and you need to respect what that parent wants, even if you do like. I feel like most of the time you and the parent are going to be thinking the same. Like we should do everything we can. Sometimes the parent is going to be like, no, I think we're good. I think you guys have done enough for my child, kind of thing. So you need to respect the parents' wishes as well, which it can be hard, especially when your opinion doesn't match theirs. But I feel like that's kind of the world that we live in right now. Like we have to have the same opinion on everything if we're going to get along, but that's not true. Like we can have different opinions and still be ethical.
Yeah, absolutely. The talking about withholding an infant's life or terminating an infant's life it is a very difficult subject, but it is important to be talked about with the parents. And for you listeners, if you are a student, it is an important thing to know that there are support systems available for you as students, and in the hospital even there's plenty of support for you if you experience one of these situations. You just need to reach out and find them. One personally to me, uh, I think that generally speaking, the doctor and the parents will be in constant communication throughout the resuscitation process, so they can make adequate decisions, and to really, make sure that this is indeed the right move. And I'm glad that Trevor pointed out that the healthcare workers in the room, even after the parents give consent to stop resuscitation, they if someone still believes that there is a chance, they will continue. I think that's a great thing to know personally. But and as like Thomas said, it's personal feelings aside, you are working as a team in resuscitation, and the parents are a part of that team as the decision makers for this patient's well-being. So it's important to have them involved with making decisions. And like I said, it's an uncomfortable subject, but it in healthcare it is very important to talk about these things, because while we always hope that it won't come up, there's always the chance. So it's better to be prepared. So, Tom, do you want to go back to your initial story?
Yeah, and totally. But before we go on, if you are going to work in healthcare, especially, and working with um, kids, adults, any age, especially when involving like emergent care, like CPR, Code Blue type stuff. I think it's good that you talk to people. You need to find out who that person is. I enjoyed talking to my wife with some things, and I've learned that she has a hard time when I talk about other things. So I feel like you need to develop that family at work so you can confide in those people that you work with. Because if not, you're gonna get burned out real quick. So I think you need to have uh, that support group wherever you're working. So I just wanted to finish that thought with that. But I kind of want to run that first baby through this algorithm that from that story I shared at the beginning. The kid made it. Don't worry. I'm trying to remember the term. I think I want one of you guys to chime in. What do they call it when you like intubate the patient, give surfactant, and then you pretty much pull it the ET tube afterwards?
Well, I think that's just surfactant delivery, without the need for being ventilated. Or
There's a word for it.
Surf
It was
and turf,
like
is that what you're talking about?
that might be it. I think it was you pretty much just intubated the kid so you could administer surfactant. There was not really another need for it.
Well,
But
Surf
there's
anyways,
and
like
turf, wasn't it?
I think it is surf and turf. Now I'm getting hungry. I want a steak and some shrimp. But
and you want
anywho,
some surfactant delivery and all that stuff.
yum yum yum.
Yeah, really get your lungs open.
Yeah. But anyways, so we're gonna run through this algorithm. Um, I think what's crucial before the birth is you definitely get information from the parents. Like have they been getting prenatal care, stuff like that. This mom had um, gestational age. Kid was 30 weeks. What other questions do we usually ask? Like preeclampsia. Like has the mom had a history of high blood pressure during this, or gestational diabetes? Like has she had a high blood sugar? Reasons why you would ask that question is um, moms that are diabetic, kids grow really quick, so you could have a really big baby. That wasn't the case in this situation. This was actually one of the smaller kids that I've seen, which I think the kid maybe weighed like 4 ounces.
Yeah, I mean, oof, tiny, tiny preemie.
Yeah,
But
yeah.
I mean, 30 weeks.
Oh,
It's
not 4 ounces. What's I think it was like 4 pounds 6 ounces.
yeah.
Sorry, I'm getting. I need to move the decimal.
I interpreted it. Don't worry. I heard
Yeah.
4, and
Well,
I was like, okay, 4 pounds, sure. But
yeah, that's
still,
still a small kid. But one of our teachers said that they've helped resuscitate kids that were less than a pound, which blows my mind. But anyways, so the kid was about 4 pounds 6 ounces, and you administer surfactant based off of weight. Um, 1 milligram per kilogram. So we know the answers to the questions pre-birth. We have birth. It was emergency C-section, so they were in a surgical room. I was just standing outside of the room. We were ready with a warmer. We had a ventilator and all this stuff just in case. Like I said, plan for the worst, hope for the best kind of thing. So the kid came out. We laid the kid under the warmer. Super blue. Didn't have a respiratory drive. Had a pulse, a really weak pulse, and slow. So obviously we weren't going to just hand the kid over to mom and say, congratulations, everything's okay. So that was a no on multiple of those questions. Kid wasn't term, kid didn't have good tone, and the kid wasn't breathing or crying. So we would go to the initial steps. So we warm and stimulated the baby. Um, the kid didn't start moving much at all. So we knew we had to start with like assisting with ventilation. So um, apnea, gasping. Gasping kind of goes along with grunting and retractions. Um, that was after we started PPV. The kids started grunting. Um, so I felt like that was an improvement from apnea to grunting, but it's still not ideal. At the time of the delivery, with my education, I thought the grunting was a good sign, like that the kid was gonna be fine. But the kid, that was a sign of uh, like increased work of breathing in this child. So we wanted to help him with his breathing, obviously. But we were administering PPV while the nurses were starting IVs and stuff like that. The nurses had a difficult time getting an IV, so they did one through the umbilical vein, uh, which, my understanding is, if I remember right, those IVs usually last like a week. It's kind of hard to get an IV on a kid when they're extremely dehydrated and small. So they just went with the umbilical vein to start an IV. I think they were giving meds. I don't really remember what they were giving, but through that. But this was kind of an emergent situation, so I imagine we're giving stuff to help with heart rate and circulate and like volume expanders and stuff like that. Eventually, heart rate was still below 100, so we would just keep going down. Check chest movement. The kid was grunting, so we did have some ventilation correction steps. I didn't really notice them doing Mr. SOPA because oxygen saturations were improving. We were kind of chasing our tails, like we were behind, but we were catching up quickly with like what our goal was for our minute ventilation. Like I mean, like our minute time for our target SpO2. Heart rate was the heart rate below 60 beats per minute. At that point, it wasn't, so we didn't have to do chest compressions, but we did intubate the patient, which you can see in the algorithm if you have that in front of you. That is something you want to consider or do after if the baby's heart rate is still below 60. But we were intubating to secure an airway. It wasn't so much emergent care to go towards chest compressions. Um, like in your first delivery, like we were kind of saying, like time seems to stand still. I lost track of time. I feel like we did that all really quick. Like I think we were still in the first 5 minutes, so I feel like it was okay that we weren't doing chest compressions just yet. But heart rate was improving. I think I told you guys it was above 100. I don't know if we were there just yet. The infant was improving, but because of the surfactant that we needed to administer and intubation, the kid went to the NICU, but was only there for like 2 days. Had a quick turnaround. The next clinical rotation I had was on a Thursday, and that delivery was on a Tuesday. And I came in, and I was kind of like, we went to the NICU, and I wanted to see if the kid was still there, and the kid was already gone home, like doing fine. Um, yeah, the only thing that kid had to deal with after the delivery was 2 broken clavicles because of the C-section, but everything else was fine at that point. So yeah, that was what I experienced, and that's what I saw. Like, I mainly saw this algorithm followed to the T almost in that situation. So it was just cool to see what you learned, put in practice.
Yeah, it's great that you got to experience this back before you knew NRP, and now looking back after knowing this information, you can see just all the steps they kind of went through and relate it so you have that real life experience. So whenever you may be actually having to follow this algorithm, you have some experience outside of doing the simulations. So it's really great.
Exactly.
So,
So Nick, I got another story. I don't know if you want me to share it with this podcast or not. I mean,
um,
like with this episode.
yeah, sure, go for it.
So this was my first kid, and when I saw NRP not, like the algorithm was not followed by any means. Want me to go for it?
If you feel comfortable with it.
Oh yeah, totally. My kid's not gonna care.
Well, it's
So
about if you care.
no, I'm fine sharing this story. Um, this is my first kid. Um, we were delivering, and it was kind of slow. And they had monitors on my kid while he was in utero, like during delivery. They were monitoring his heart rate really closely, and delivery wasn't going fast enough. My kid's heart rate was starting to drop, so they had to use a suction cup on his head to get him out of the birth canal. And he had a little bit of a cone head, but don't worry, that goes away after some time. Um, he came out. I was really nervous. He wasn't crying. He was like super blue and purple. My wife was crying her eyes out because she was just happy we had a kid, and I was just I know I had a deer in headlights look because I'm like, this is not normal, this is not good. But they like quickly dried and stimulated the kid, let my wife hold him for like a minute, which I understand people are paranoid about, the like obsessed with skin to skin connection kind of thing. But I felt like we needed to start like I guess now that I know, like I felt like they needed to start NRP right then and there. Um, I didn't see them with PPV in that room. They pretty much just suctioned, and they took my kid to the NICU right after. Um, Luckily, they didn't do chest compressions right off the bat because that's a no-no in NRP. Like you want to wait a while before you do that. So I'm grateful they didn't do that. But I remember going to the NICU and seeing him, and he had an IV on the top of his head. Don't worry. Uh, my first thought was he looks like a unicorn, but that's where a good vein is in newborns, is in their on top of their head, and he just needed like a little bit of oxygen. I think he was on. It's crazy, kids. Like we get to the decimal points of liter flow per minute. I think he was on like 0.5, maybe even less than that. But he just needed a little bit of oxygen and some lung recruitment. So he was fine when I went and checked on him, but that was like an hour later. They wouldn't let me see him for like an hour. There was a lot of things I wish they would have done differently with that, with my first son's delivery. One of the things was the steroids, like we talked about earlier. I didn't even know that was an option back then, or I would have harped on the doctor a little bit more to give those, because we were planning on delivering my firstborn about a month early, but he obviously wanted to see the world before that. So he was about 6 weeks early, and he didn't have the steroids, so obviously his lungs weren't as developed as you would probably want them to be. Um, and then he was kind of just enjoying life where he was. He didn't really want to eat much either, which we've kind of joked about, Drew and Trevor, about like nutrition when dealing with a patient that's struggling to breathe, like the respiratory drive, because it does take some energy. But yeah, that was his biggest issues was eating and breathing, and I felt like early interventions would have been better than dealing with it after the fact.
Yeah, it's unfortunate that that happened, but at
Right.
least on the bright side, um, you now have that as an example of what not to do. So that's at least
Right, exactly.
a bright side out of that. I hope your son is doing well.
Oh, I don't want our listeners to get the wrong idea. He is perfectly healthy and fine now, but there's some things that I wish would have happened earlier. But he's great. He's healthy, and he's just a perfect kid in my opinion.
Oh, wonderful. So, listeners, that is the end of this podcast. We this was a a brief overlook and discussion about NRP, neonatal resuscitation, and I hope you enjoyed. And we will see you next time. This has been Don't Hate, Ventilate. See you then.